afternoon to our Facebook community, and welcome to our Facebook Live session for American Stroke Month. My name is Dr. Amaya Kulkarni. I am a board-certified cardiologist at the Mid-Atlantic Permanente Medical Group, and I am so delighted to host this session with three of my colleagues. Today, we're going to talk about the symptoms, treatment, and most importantly, the prevention of strokes. So I have three of my incredible physician colleagues with me, and I'm going to ask each of them to introduce themselves. Dr. Ackerman, our board-certified neurologist, would you mind introducing yourself?
Hi, I'm Dr. Ella Ackerman, and I'm a board-certified neurologist at Mid-Atlantic Permanente Medical Group in the District of Columbia and Maryland region.
Wonderful, welcome. And Dr. Amanda Bauer?
Hi, I'm Dr. Amanda Bauer. I'm a board-certified emergency medicine physician with the Mid-Atlantic Permanente Medical Group in Baltimore.
Wonderful. And Dr. Lodato?
Hello, I'm Joe Lodato, and I'm a board-certified cardiologist with the Mid-Atlantic Permanente Medical Group, and I work in the DC and suburban Maryland practice.
Awesome. Well, welcome to all of you, and I'm really excited to have this conversation. I feel like we're going to share some wonderful information with our Facebook community. Dr. Lodato, I'm going to start with you. I would love to ask you something that a lot of our patients, yours and mine, ask all the time. How do you prevent a stroke, and what are the risk factors?
Well, that's a really great question. And as a cardiologist who deals with heart attacks, I like to think of strokes as a brain attack. These are very similar pathologies that cause heart attacks and brain attacks, and they have similar risk factors as well. So when I think about heart attack risk factors and brain attack risk factors or stroke risk factors, some that come to mind are those that we can modify, so something we can do something about, and others that maybe we can't do anything about, things like our family history or our genetics. Maybe we have a history of heart disease or previous stroke. But let's focus on the things that we can do something about. We call those modifiable risk factors. And the big ones are smoking. Smoking is a very common risk factor in patients who come in with stroke. And that can really include any kind of smoking. So anything that you're inhaling into your body, any type of particulate matter is not good for your body in general, but definitely not good for your arteries. High blood pressure is a common risk factor in stroke as well. High blood pressure puts stress on your artery walls, and that can also make the blood kind of sticky and prone to forming clots. Metabolic disorders like diabetes, high cholesterol, obesity, and inactivity. And then, of course, other things that we take into our bodies, alcohol and illegal drugs, those can put us at higher risk of stroke. And then a history of heart or vascular disease. And then some abnormal heart rhythms that are near and dear to my profession, things like atrial fibrillation or atrial flutter. Those are some of the more common risk factors for stroke, and those are what I consider the modifiable risk factors. And then we touched earlier a little bit on some non-modifiable risk factors. So genetics and family history, of course, age, we can't do anything about. And then gender and race also have important roles to play in stroke and how people respond to stroke. Stroke is much more common in men, for example, but women are more likely to die from a stroke. And of course, race, where you live, what your socioeconomic background is, these are all other factors that can impact stroke and how you respond to stroke.
Thanks, Dr. Lodato. And I really like how you frame that as sort of the modifiable and non-modifiable risk factors, because it gives people a path. Sort of, once you know what you can change, you can work on changing it. And those seem like, I know we're going to talk about the things you can change to make your stroke risk less. One thing that you mentioned, I'd love Dr. Bauer to sort of weigh in on a little bit, is the gender differences, the sex differences between stroke risk factors and symptoms. So maybe Dr. Bauer, you could talk a little bit about, are there gender differences in stroke? And if so, how should we think about that?
Yeah, absolutely. And I think it's a really important thing just for awareness to be aware that the risk factors in women may be a little different. So everything that Dr. Lodato spoke about is true for women too. And on top of that, we have hormonal risks. And these hormonal risks make you more prone to stroke actually when you're pregnant and immediately postpartum. So that's often younger, and sometimes we don't think about stroke in that age group. So it's important to have that awareness. And then the other phase is during menopause, and particularly with hormone replacement therapy, it is an increased risk for stroke. And as Dr. Lodato shared, women are more likely to die of stroke. In fact, it's the third leading cause of death for women. So especially important to be aware of your risk factors, modify the ones that you can, especially because there's so many that we can't. I mean, I wish we could modify age, but that does not seem to happen.
Well, thank you. Yes, and critically important to sort of talk about the fact that women are much more likely to die from stroke, sort of emphasizing the importance of prevention. Dr. Ackerman, tell us a little bit about, let's say, somebody thinks they're having a stroke. What are the common symptoms that we consider in a stroke? Dr. Ackerman, I think you're on mute.
Yes. There is a very important mnemonic that everyone should know. The mnemonic is FAST: face, arm, speech, telephone. And the reason is face, crooked face, meaning a facial droop. The bottom of the face will be drooping on one side. And if you were to smile, there will be asymmetric smile usually. But even without smiling, if you just look at yourself in the mirror, you may notice that one side of the face may be drooping down, just the bottom side of the face. And the other one is speech. Arm. A is for arm. The easiest way of doing this test is to simply put your arms up in front of the mirror and close your eyes for just 10 seconds or so and open your eyes again. If one arm has drifted even slightly, that would be a sign of possible weakness in the arm and stroke. Speech, trying to speak to yourself, or if you're not sure, recording yourself on the phone. Everyone has a cell phone next to them now and can record themselves. But just saying something like, today is a nice day, or I went to the store, or something silly if you're by yourself, and if the words are not coming out right, that is concerning. And if that happens, you have to dial 911, telephone. And so these are the top symptoms to watch out for. And the key is they're sudden. It's not something that gradually comes on. I tell my patients, it's sort of equivalent to turning off the light in the room, like someone turned off the switch, that the lamp suddenly turned off. If that happens, that's very concerning for a stroke. The other important sign of bleeding stroke specifically is sudden worst headache you've never experienced before, an explosive headache. The worst explosive headache, that is a very concerning symptom. You should not ignore it, especially if it's also associated with a stroke symptom. So, and again, it's a sudden symptom. Now, the other symptoms of stroke that people don't tend to think about are visual symptoms. Visual symptoms that come on suddenly are concerning, specifically loss of vision, not extra sensations in vision, such as squiggly lines or perhaps lopsided vision or whatever, but loss of part of the vision or the entire field of vision in one or both eyes. So it's important, if that happens, to cover one of the eyes and seeing, is it just one eye or is it both eyes that you're missing vision in? And if it's in just one eye, it may be concerning. Or if it's the whole field of vision where you don't see anything to the right of yourself or to the left of yourself in both eyes, that would also be concerning. The visual symptoms should not be ignored. And finally, loss of sensation, not being able to feel something suddenly on part of your body. Suddenly, again, like someone turned off the lights in part of your body, you suddenly cannot feel something in that part of the body. That is also concerning for a stroke. So I just wanted to, add to the F.A.S.T mnemonic, the sensory symptoms that suddenly occur or visual symptoms that suddenly occur. And the key is loss of function, not extra sensations, not tingling, not weird sensations, loss of sensation, loss of vision. That is concerning for a stroke.
Thanks, Dr. Ackerman. That's a really great summary, and I love the practical tips you give because, as we all know, in our practices, and sometimes symptoms are unclear to patients, and so the sort of idea of putting your arms out or covering one eye or another, really great practical tips on how to assess whether the symptoms are related to stroke. All right, so Dr. Bauer, as our board certified emergency physician, let's say somebody has one of these symptoms concerning for stroke. Tell us, like, what do you think they should be doing? And as a caregiver, if you notice one of your loved ones having this event, what would you recommend the caregiver do and pay attention to?
Yeah. So, I would follow up on the F.A.S.T thing, that last T, the time to call 911. That is really important because this is not the time to hesitate. If you think it could possibly be a stroke, you need to call 911. And it's not the time to think about, as a caregiver, driving your family member, even if you're like 5 minutes from the hospital. You really need to call 911 because the paramedics that arrive have different support capability than we do as caregivers. And on top of that, they're going to make sure that the hospital you go to is a stroke center that can take care of a stroke. They're going to notify the hospital ahead of time so the ER knows you're coming and that you have a possible stroke, because time is really important when it comes to stroke management and care. And that, I think many people have heard about IV thrombolytics or clot busters that can actually reverse some of the symptoms of the stroke. And they are most effective when right away, or the sooner possible, the least side effects there's going to be. And once you get to like 4.5 hours, the risks and benefits don't really weigh out most of the time. So that time period is really important. And what the ER is going to want to know from you as a caregiver or from the patient is, when were you last normal? So when was this last without these symptoms, without the symptoms you're now having? When was the time that you were normal? That's going to be an important factor. You may ask about medications and some of the recent health history. So if you are a caregiver and your family member is having significant symptoms, it's important to go with them to be able to share these important findings, like the timing, and be sure you're there with them for support in the ER.
Thanks, Dr. Bauer. So just to recap, because I think this part is probably the most important part of what we're talking about. If you're noticing stroke symptoms in yourself, or you're the caregiver of somebody who's noticing stroke symptoms, number one is to call 911, get to care as fast as possible. And then the third thing you said is the caregiver's last known normal is super important, because there's some therapies we can do if a patient gets to the centers fast. Dr. Ackerman, maybe you could sort of fill in a little bit about, from a neurologist perspective, you get a call that somebody in the emergency, Dr. Bauer has called you and said, look, I think I have a patient who's having a stroke. What are you thinking about the immediate care in terms of the options that we have when a patient presents with a stroke?
I agree with Dr. Bauer. The first step is we ask, when was the last time this person was normal? Either they knew it or their caregivers knew it. Unfortunately, a lot of strokes happen in their sleep. And so what time did you go to bed? Do you remember? How did you feel when you went to bed? The other important point is this person taking a blood thinner? If the person is taking either Coumadin or one of the newer anticoagulant medications, such as Pradaxa, there is Eliquis, there are Xarelto, there are several, but we are somewhat limited in our options in the patients who take anticoagulation, unfortunately. But it does not eliminate the options. And that's what people need to understand. And not only that, it's not just about the options in terms of immediate stroke treatment. It's also importance of being seen in the hospital as soon as possible for stroke care overall, because we do not know when we hear about someone having a stroke, whether this is a big stroke or small stroke necessarily. A very small area of the brain that is affected by stroke can sometimes produce devastating disabilities, and vice versa. Sometimes large strokes, surprisingly, may produce very little disability immediately. And when you are diagnosing yourself with a stroke, you do not know how it's going to go in the next 15 minutes, 30 minutes, an hour, 24 hours, 48 hours. So that is why it's important to just call 911 and get evaluated as soon as possible. Any stroke is an emergency. It can become very bad very quick. And treat stroke like you would treat a heart attack.
As Dr. Lodato says, a brain attack. So I'm going to stay on you for 1 second, Dr. Ackerman. Okay, so now a patient of yours has had a stroke. They've gotten the best possible treatment they can, and now they're ready to leave the hospital. What can they expect? What does post-stroke care look like? What are the things that they will be seeing in the next few months?
Correct. So by definition, stroke is going to cause loss of brain tissue, right? That is why we call it stroke. That's the difference between stroke and TIA, where transient ischemic attack, it does not cause permanent damage to brain tissue, but stroke does. So as a result, a person will have some sort of loss of function. Fortunately, we only use about 30 to 40% of our brain tissue at any given time. So there is a lot of redundant brain tissue that is capable of taking over function for the tissue that is lost. And that is why stroke rehabilitation works. And it has to be implemented at the earliest opportunity after a stroke. Now, there are some devastating strokes, unfortunately, that cause permanent loss of function that will not completely improve to baseline, to prior baseline before the stroke. And that is why it's so important to prevent a stroke, because stroke often can cause permanent disability. But with rehabilitation, you will still improve. Now, how long does this process take? Well, the general principle is you have to give yourself good 90 days after a stroke to know what your new baseline is going to be. At 90 days, in general, this is a general principle. If there is a certain function, certain aspect of function that has not improved at all since the stroke, it is very unlikely it will improve significantly after 90 days. Okay, so basically at 90 days, it's a good new baseline to go from, as far as this is going to be your new baseline after stroke, pretty much. If anything is going to improve from that point on, it's going to be those aspects of function that have already started improving since the stroke. And those may improve a little bit more after 90 days by maybe about another 10% or so. Majority of stroke recovery does happen in the first 90 days, however. That is why early rehabilitation is so crucial. That brain plasticity, whatever is there, it needs to be taken advantage of as soon as possible after a stroke. That's why inpatient rehabilitation, then also outpatient rehabilitation, in-home rehabilitation, it all is so important. And patients need to be encouraged that even on the days when they do not see their therapists, that they have to continue their rehabilitation on their own and continue doing that rehabilitation as much as possible, especially in the first 90 days.
Thanks. I think that's a really critical point you made, which is that we talked about how time is important in the diagnosis of stroke and the initial treatment, but even in the first 90 days, getting into stroke rehab early and getting on appropriate therapies is really important. So Dr. Lodato, we started with you by asking what are the risk factors for stroke, and I'd love to sort of ask you now, number one, what are the things that an individual can do to prevent a stroke using those modifiable risk factors? And then if they've had a stroke, is there anything they can do to prevent a second stroke? So I'd love for you to share your expertise on that.
Thank you. Yes. So first of all, it's never too late to make a healthy change that can have tremendous impact on your future health, whether you've had a stroke or you're simply at risk for stroke based on some of those risk factors we talked about before. And it's really important that you control the things that you can control. Number one, the most impactful change that you can make on your overall health and certainly your cardiovascular health is to stop smoking. Smoking cessation has tremendous benefits, and those benefits occur very early on after you stop smoking. So that's probably the most impactful thing that you can do. Next would be to work with your doctor to make sure that all of the medical conditions that you have that might place you at risk for stroke are under the best control that they can be under. So that might be managing your blood pressure, diabetes, or cholesterol. Then we would move on to things like weight. If you're overweight or obese, you should really make an effort to reduce your weight. There's evidence that weight loss does reduce the risk of cardiovascular events like heart attack and stroke. And you should lose that weight in a healthy way. Exercise and diet can be thought of as medicine, just like medicines can. The best thing about exercise and diet is generally doesn't have side effects and it's free. So you should be out there exercising, making an effort to get at least 30 minutes of exercise on most days of the week. Find a diet that you can stick with. Some very good diets for cardiovascular risk prevention include the Mediterranean diet, pescatarian diet, vegetarian diet. Whatever diet that you choose, it should be one that you can stick with, a lifestyle change that you can stay with indefinitely. Other ways to help reduce your risk of having another stroke or preventing a first stroke would be to reduce or eliminate your alcohol consumption. I think there's a myth that has been perpetuated by not only the medical industry, but now in the lay community as well, and that is that drinking red wine every day or moderate alcohol consumption every day is healthy. And we're slowly starting to dispel that myth. No one should drink alcohol every day. It's okay to drink maybe 3 or 4 days of the week, but certainly no more than 1 or 2 servings whenever you do drink alcohol. There's plenty of evidence that binge drinking can put one at risk for not only stroke, but also raises blood pressure and can contribute to other heart rhythm disorders like atrial fibrillation.
Great. Well, thank you, Dr. Lodato, for sharing that. I want to just emphasize one of the things that you said, which is about the exercise and diet having few side effects and being free. I think that we don't often think about exercise and diet as a medication, but there is good data to show, as you were suggesting, that it has similar effects to some medications in terms of reducing cholesterol and blood pressure. So it's an important adjunct to our core therapies. Thank you for saying that. I do want to give all three of you a chance to sort of share some parting wisdom. But before I do that, I want to tell you all a story because I can. So just in terms of the exercise being free, you guys may or may not know this, but the American Heart Association does a race called the Lawyers Have Heart Race in May every year. So it just happened this past weekend or the weekend before. It can be a 5K or a 10K. My 77-year-old father, who was athletic in his youth, but has sort of fallen off of his athletic abilities as he's gotten into his 70s. I signed him up for the 5K as a walk, and I told him I'm signing you up for the 5K, and he used that as a motivating tool to start walking every day. And so he walked 3 miles a day in the time leading up to it. And I got to tell you, he is in better shape than he's been in 10 years. And that simple engagement with daily activity has probably had a substantial effect on his stroke and heart attack risk. And so, sort of creating, I think the lesson for me is in creating sort of anchors, things to achieve for, I think are sometimes helpful in exercise goals. So that's my one story for the day. And so maybe we'll just go around. And Dr. Bauer, maybe we can start with you and tell us anything else you want to add to this conversation about stroke risk and prevention.
Yeah, I think it's like such a great story. Think of family together, walking, just getting active and outside. I think we sometimes think exercise and think it has to be something big. And just to walk, just to move, there's people that say the sitting is the new smoking. Like, just don't sit. Like, move, walk, get up, do things, get your 10,000 steps a day, whatever it is. But it's so important because strokes can be debilitating. And, if you suddenly don't have use of your arm or can't walk on your own, or your family member suffers that, it's such an emotional and physical hit. And it's like, and there's little things we can do to make that less likely, both for ourselves and for our family. So it's like, just maybe together, do things, walk more, eat better together, skip the alcohol, just a few things together, because stroke is so devastating and it's something we just would not want for ourselves or our loved ones.
Yeah, I love the sort of sitting is the new smoking as a concept. I think that's so true, especially as we get into the world of telework. I think that the sort of the natural steps we would take in a day in an office are sometimes going away. So that's a great call out. Dr. Ackerman, I'm going to give you a chance to tell us your thoughts. But we do have a question from the Facebook Live community, and I'd love to ask it to you. Somebody's asking, is somebody in their early 20s, do I have to be worried about having a stroke?
Unfortunately, yes. Some more than others, especially if you have strong family history. You cannot, unfortunately, underestimate family history. If you have first-degree relative with early strokes, strokes before age 50, if you have high blood pressure, if you are a smoker, those are real risk factors. If you are a binge drinker, if you drink excessive amounts of alcohol, if you're using drugs, specifically cocaine is a very high risk factor for strokes. So yes. And then unfortunately, there are some strokes in the young that anyone can be at risk for. They're rare, but people need to be aware of it, because our culture is a culture of experience and experiment, and some experiences and some experiments may not be the wisest. For example, chiropractic manipulation is a real risk factor for dissection of the arteries in the neck. Sudden snapping of the neck, sudden neck trauma can create a tear in the arteries of the neck. So have to be careful with manipulating your neck. Don't be too excited about it. Be careful. Whoever does your manipulation of the neck, make sure they know what they're doing. And of course, if there are cardiac defects in certain people, they would need to be aware of those, because strokes can come from the arteries, but strokes can also come from the heart. And so, yes, in the younger population, they're rare, but you do need to be aware of them. And finally, last but not least, certain hormonal therapies can be associated with strokes, and women on any of those hormonal therapies, strokes during pregnancy, that is rare, but it can be a cause of stroke. So education about strokes, learning about strokes is very important.
Yeah, and within that, I heard the wisdom of Dr. Lodato between the modifiable and non-modifiable risk factors. And so things like smoking, if you're smoking, to stop smoking, if illicit drug use, including cocaine in particular, those are all things that increase people's risk of stroke at any age. And so those are things that we can modify now. So yeah, that's great. Thank you for sharing that. We have another question from the Facebook community, and Dr. Bauer, I think I'd like to ask this one to you. So the question was, is there a difference between facial paralysis and a stroke? And so maybe I'll reframe that to say, when you see a patient with evidence of facial paralysis, how do you distinguish between a stroke and other causes?
Yeah. So the first thing I would say is that any facial paralysis, any weakness, this is not something for you as a family member or you as a patient to determine if it's a stroke or not. Sometimes the differences can be subtle. So still, you treat it, if you see facial weakness and you have not had it before, as Dr. Ackerman said, it came on suddenly, call 911. This is not something for you to figure out or your family member to figure out. It's something to bring to the emergency room and have the emergency physician assess whether this fits with a stroke or doesn't fit with a stroke. There are, facial palsies. They talk about Bell's palsy is the one most commonly thought of, which will have, weakness, the whole side versus part of the side. But again, it's subtle. There's subtle findings that may not be obvious to a lay person. So it's important you come to an emergency physician, come into the ER, call 911. Don't try and determine if it's a stroke or not yourself.
Yeah, I think that's really fabulous advice. So if you have something that's new onset, that is a change from your current state, best to be checked out so that using our tools and techniques we can distinguish. And as you were saying, paralysis is just sort of loss of function of a nerve, and that cause can be due to a stroke or some other things like a palsy, as you were saying. That's great. All right, so Dr. Lodato, I didn't get a chance to ask you sort of any parting thoughts or wisdom you'd like to share with the group.
I would just emphasize the fact that I think has been emphasized by everybody already, and that is that exercise and food are medicine. Just like pills that we prescribe as doctors, exercise and food are medicine, and they can have powerful impacts on your health and your longevity.
That's a fabulous message to end our Facebook Live on. I want to thank you all for being a part of our conversation today, and everyone in the Facebook community. Thank you for joining us as well. Just to reemphasize, the most important thing you can do when it comes to reducing your risk of having a stroke is to focus on modifiable risk factors like smoking, diet, and exercise, and then talking to your doctor about things like high blood pressure and cholesterol. If you have a stroke or have signs and symptoms of a stroke, the most important thing you can do for yourself is get to care as fast as possible and know the last time you were last status as normal. Those are the important factors to know. And then after a stroke, it's important to have hope, because as Dr. Ackerman said, there is the brain is plastic, and so that there is the opportunity for us to recover a decent amount of our function because the brain is an impressive organ. And the most important thing after a stroke is the same as before, which is to focus on the modifiable risk factors. So with that, I want to thank you all for joining us, and hopefully we'll see you at the next Facebook Live. Thanks so much.